Welcome to this presentation on breast ultrasound. My name's Stephen Bird. I'm a general sonographer living in Adelaide. If you enjoy this presentation, please visit birdultrasound.com.au and you'll find plenty more material on a wide range of topics. This is the Canon i800 ultrasound machine that I use on a regular basis for breast ultrasound. You'll notice immediately that there's 3 transducers sitting on the machine, and all 3 of these transducers I'm going to use on a regular basis. This 14L5 transducer I find very versatile. I use this on larger breasts and on medium-sized breasts, and it has a nice wide aperture, which means that I can survey the breast easily with this wide field of view. The second transducer that I use I use this on larger breasts when I'm targeting a particular lesion that's in the more superficial component, and I also use this on the smaller A cup or B cup type breasts. So this is an I18 transducer. It's a matrix probe, which means it has really thin slice thickness and gives exquisite resolution. The third transducer that I use on a regular basis is this little fella here, the hockey stick transducer. So this is a 22 megahertz hockey stick transducer. I call this the ultrasound microscope because it really is like looking through a microscope when you put it on a lesion that's in the near field of the breast. I use this for all lesions up to a couple of centimetres in depth, and it's remarkable the extra detail that I get if I'm trying to discern whether something is an area of fibrocystic change, for example, or whether in fact it has genuine solid components and maybe a cellular type of carcinoma. All 3 of these transducers offer Doppler functionality. So the question I have most commonly when I'm doing breast ultrasound is a simple one. Is there flow in that lesion or is there not? And that's how I differentiate between, say, an imposated cyst and a fibroadenoma or a breast cancer. To answer that question, I use 2 key technologies. I use SMI, which is superb microvascular imaging, and I use ADF, which is advanced dynamic flow. Both of these technologies offer exquisite low flow sensitivity and very, very high spatial resolution. So by using a combination of these 3 wonderful transducers and these 2 unique Doppler algorithms, I feel really well equipped to perform my breast ultrasound. Image optimization is key to all ultrasound, but most certainly in the breast it's most important. I use a range of transducers when I'm performing a breast ultrasound. I'll use a long linear array transducer of a mid-range frequency, then I'll use a shorter high-frequency transducer to look at lesions that are a bit more superficial, and then quite often I'll pull out the hockey stick very high-frequency transducer to have a look at things that are just underneath the skin or around the areola or just deep to the nipple. So I'm not scared to use a range of transducers. When you're adjusting the depth for a breast ultrasound, it's most important that you can see the lungs. You need to see the pleura at the bottom of the image. This means you're not going to miss anything that's right at the back of the breast or invading the pectoralis fascia. Harmonics we use almost routinely in ultrasound now. In fact, it's quite unusual for me to turn harmonics off doing my day-to-day work. But in the breast situation, it's most important to remember that it's not compulsory. So you can turn the harmonics on, you can also turn them off. And this will give quite a different looking image, and it can help you to determine if something is cystic or solid and to have a look at the margins and the definition of lesions. I feel the same way about real-time compound imaging. I really don't turn it off for any other type of ultrasound these days except for breast ultrasound. But sometimes in the breast, if I want to see if something is shadowing and I want to get a little bit different look at it, I turn the compound imaging off. It gives me a very raw image to look at, but sometimes this can just help me to make my mind up about a lesion. The speed of sound correction I use all the time in breast ultrasound, and I'll show you an example of how this works in just a second. With Doppler in the breast, it's a very simple thing. I just want to ask the question, is there flow or is there no flow in this particular piece of tissue? So if it's an imposated cyst, or I'm thinking maybe it's a fibroadenoma, or is this some fibrocystic disease, or am I looking at a cellular lesion with some cystic spaces, the Doppler can be the key. So I use technology such as SMI and ADF, advanced dynamic flow, because of their low flow sensitivity. The wide view or trapezoid view I never use, because the moment you go into trapezoid view, your image resolution will slightly deteriorate, not markedly, but just slightly, and I really don't want to pay that price for the extra field of view. I will turn the trapezoid or wide view function on if I'm trying to measure a large lesion, and also like to have it on when I'm doing guided interventions, as it helps to pick up the needle a little bit earlier. This is an example of me optimizing the tissue-specific optimization, or TSO. So this is adjusting the speed of sound assumption that the machine's making. If you look at this image, I'm just keeping the transducer exactly still, and at the beginning of the image, it's a poorly optimized TSO, and at the end of the image, it is optimized to match the speed of sound traveling through this breast. And you can see how the image sharpens considerably. So it looks like an unfocused image, and then as the video rolls through to the end, you end up with a very sharp image at the end. So I'll even adjust my TSO for different parts of the breast depending on how much glandular tissue there is in that individual component. This is an example of SMI, so superb microvascular imaging. When I see a lesion in a breast, if I'm thinking, is it a large imposated cyst? Is it a solid mass? I want to know if it has vascularity to it. It's a very, very simple question. Is there flow in that? And to answer that question, I tend to use SMI as my first option because that's the most sensitive algorithm we have for low flow states. And if I don't have that available, I'll use the Advanced Dynamic Flow, or ADF. Remember that breast ultrasound is a very collaborative investigative procedure. It starts with the referrer and what's written on the referral. Then I have a chat to the patient and find out what their symptoms are and what made them go to the doctor to come along for a scan. I'll have a chat to the radiologist because they've hopefully already had a look at the mammogram, and I'll have a chat to the mammographer as well to see what she's noticed when she's examined the patient clinically and had a chat as well, because there may be other little clues in the history that come out in one room that don't come out in the next room. The next job is up to the sonographer, and then they come to me and I'll perform the examination, drawing on all of the information that I've gleaned from those other sources, and then eventually onto the breast surgeon. So where I work in Adelaide, we have a beautiful situation where we have obviously a patient, but we also have a radiologist, a highly skilled mammographer, the sonographer and the breast surgeon all in the same clinic at the same time, so we can all discuss the case together and we can provide a really wonderful service for that patient. Something we always ask patients is about their family history, and if you ask a patient, oh, do you have a family history? And I often go, oh yes, I do have a family history. And when you say, well, explain the family history to me, it's sort of some long-lost auntie that's about 5 generations away that had a breast cancer late in her life. And that's not really a family history. Poor old long-lost auntie is obviously someone we love, but her breast cancer is not going to impact upon that lady's individual risk profile. So what we define as a significant family history is a first-degree relative. So it has to be your mum, your dad, your sister, your brother, your daughter, or your son. So they're first-degree relatives, and so a significant family history is a first-degree relative with a breast cancer diagnosed before the age of 50, or a first-degree relative with a breast cancer in both breasts diagnosed at any age, or 2 or more first-degree relatives with breast cancers at any age. Now, if you can tick one of those 3 boxes, you've got a significant family history, and in that case, we might start doing your annual surveillance a little earlier. Before I actually begin the scan, as I mentioned, I have a look at the mammogram first, chat to the radiologist and their mammographer to get information from them. And then once I ask the patient to come into the room, I ask them about their symptoms. And if it's a palpable lump, I ask them to find it. So I ask them to try very carefully to find the lump. Often it goes missing, but if they can find the lump or at least show me the area, then that's very helpful. And then with permission, I'll then palpate the lump myself, because it's most important that I can feel the lump, and then I get a bit of an idea myself whether I feel like it's going to be a highly mobile lump like a fibroadenoma, or whether it feels like normal glandular breast tissue, or whether it feels like something that's sinister for a cancer. Remember, there's always a reason for a palpable lump. It might be a little lipoma, it might be some glandular tissue, it might be something sinister, it might be a benign lesion, but there's always a reason for the lump. And at the end of the scan, I like to at least be able to tell the lady that the lump is there for a particular reason. The sonographic technique I use to scan is to scan radial first and then anti-radial. The breast is made up of a number of, if you like, little florets, which have ducts going back to terminal ductal lactation units, these little lobules here. And so they're arranged in a very radial fashion. So I feel like if I scan around radially, then I line up along the architecture of the breast. So I scan like this, I go around the breast, and I label these, 12 o'clock, 1 o'clock, 2 o'clock, etc. And I scan in a very radial fashion from the nipple. The next thing that I like to do is to scan in an anti-radial fashion. So I scan from the areolar margin right out to the edge of the breast to make sure that I get all the way out to the edge of the breast, and I comb around the breast, making sure that I look at the entirety of the breast, and I do this in real time. I don't take any additional pictures unless there's something of significance there that I'm interested in. There's a couple of areas of the breast that I really worry that I can miss things using this technique. The first area is the area right around the periphery of the breast. So I then take the transducer, because the length of the transducer is not long enough to cover this on my radial scans, I take the transducer right to the periphery of the breast and I comb right around the margin of it just to make sure I'm not missing something that's right on the periphery of the breast. And then I feel the same way about the nipple as well. When I get to the nipple component, I feel like I haven't looked underneath it, and I'll show you how I examine the nipple and the area underneath the nipple shortly. The last component is to go to the axilla and treat the axilla as a separate area also. So go to the axilla and comb this area very carefully in long and short axis, looking for lymph nodes, looking for accessory breast tissue, and looking for any other sinister lesion that might be in the area of the axilla. When we look at a breast ultrasound image, there's a lot of anatomy in the breast, and there's a long list of all the bits and pieces that you're going to see when you're scanning through a breast. I'll give you another picture to have a look at, which sort of shows these nice areas of individual components of the breast. Running through the breast, there's two fascial planes. There's this plane through here, which is the premammary fascia. So everything superficial to the premammary fascia is the subcutaneous fat and the skin. And then, of course, also the Cooper's ligaments also run up through this area, and you can see them here and here. Underneath the premammary fascia, we have the glandular component of the breast, and this is where the ductal component is. This is where the lactating units are in the breast, and it's also where the majority of our breast cancers arise from. Deep to the glandular component, we have this retromammary fascia. And in this patient, the retromammary fascia sits right on the pectoralis muscle. There's only a little small piece of retromammary fat here. And then deep to that, we've got the pectoralis fascia. And then underneath that, you can see intercostal muscles, ribs, and then right at the bottom here, we've got the pleura. So this is a really nice example of how we can see the anatomy of the breast from the skin right through to the pleura. And this is how we have to image a breast. Breasts can be described using a BI-RADS density formula from A, B, C, or D. So BI-RADS type A and B breasts are very fatty involuted, and I call these breasts sort of transparent breasts, if you like, on a mammogram. They're beautiful for mammography because nothing can really hide in them. There's only a small amount of glandular tissue left behind, and any solid lesion is going to be very conspicuous on the mammogram. Ultrasound in BI-RADS A and B breasts is really limited in its usefulness, only just for targeting lesions that are seen on the mammogram. But with these dense breasts, so BI-RADS C and D breasts, which have a lot of glandular tissue, these are very difficult to interpret with mammography alone, and the ultrasound has a really key role to play here in assessment of BI-RADS C and D breast types for finding small cancers in amongst that dense glandular tissue that you can see just makes a snowstorm out of the mammogram. When we look at the mammogram, it's important we look for symmetry, and the radiologist will help you with this. You don't need to know these skills yourself, but I'm a radiographer, so I look at a lot of mammograms anyway, and you can see these patients here have beautiful symmetry, so nice symmetry from right to left, so no real problem here. But then other patients will have this marked asymmetry. If you look at the right breast of this patient, it really looks like a breast that is probably 10 years younger than the left breast. The left breast has got a lot more fatty involution and a lot less glandular breast tissue. It almost looks like they belong to two different patients. So what we need to establish here is what's causing this extra density here. Make sure it's just healthy glandular tissue and nothing more sinister. So often the radiologist will come to the sonographer and say, I've got an asymmetrical density, and this is an asymmetrical density in a breast. It's a lot of glandular tissue in this sort of upper outer quadrant that's present in the left breast, but not the right breast. And when we look in this upper outer quadrant at 1 o'clock in the left breast, you can see it corresponds almost exactly the perfect shape as well to this wedge of glandular tissue, perfectly normal. There's no lesion here, no mass, just normal glandular tissue. Once again, you can see quite marked asymmetry here between the right and left breast, with the right breast having a lot more density to it. So when we scan the right breast up at that 11 o'clock area, so upper outer quadrant again, you can see there's a big bank of glandular breast tissue that explains that density. And then what I like to do is do like a split screen comparison where I can show that the right breast at 11 o'clock, and of course the left breast using the mirror image is at 1 o'clock, so the same sort of upper outer quadrant. There's a lot more glandular tissue in the right breast that is corresponding to this density on the mammogram, but again, no sinister lesion. So it's most important that the mammogram and the ultrasound have a really nice correlation. So we have a fairly obvious spiculated breast cancer here in this breast, and then the ultrasound shows a spiculated lesion exactly the same location as what we expect to find it from the mammogram. So a very good tight correlation. If you don't have a correlation, you might be dealing with multifocal disease. Shadowing in a dense breast is a real problem for ultrasound, and we can deal with it in a range of different ways. You can try a different transducer. If you're using a really high frequency transducer, sometimes going to a slightly lower frequency transducer will reduce the amount of shadowing that you're getting in the image. Real-time compound imaging can help to reduce the amount of shadowing as well. So turning your compound imaging up or down, experimenting with that can also help with management of shadowing. The amount of compression you're using with a transducer, I think, is probably the most powerful tool we have. So using compression, so squashing the breast tissue out, coming at it from a different angle, laying the breast tissue on the side, and sometimes using a bimanual approach where I use my left hand as well to sort of roll the breast tissue over and come at it from a different angle, means that I hit the Cooper's ligaments at a different angle, the shadowing goes away, and I can see there's actually normal breast tissue there, and there's no longer anything sinister in that part of the breast. Heel and toeing the transducer, approaching from different directions, being really versatile with your technique. And then if you've got a persistent shadow, if you sit on that shadow and then you literally just turn the transducer through 360 degrees while heel and toeing on it at different angles, you can really work out whether or not that shadowing is persistent and represents a sinister lesion, or whether it's simply a bit of just edge effect from the edge of a bit of glandular tissue, or a Cooper's ligament shadow giving you that shadowing effect. And then sometimes just rolling the patient a bit more or a bit less. I always set my ladies up in what I call a balanced position, where I put a triangular sponge under them, roll them up until the breast is just nicely balanced. So you can change them, you can roll them back a little bit flatter or a bit steeper to look at a particular part of the breast. So these are beautiful pictures done by Emma Godric, who's the senior tutor at the practice I work for. And you can see the way that she's had some issues with some shadowing here and some issues with some shadowing here. And then just by changing the pressure of the transducer and using some of those techniques, you can see that the shadowing is markedly reduced on this image on this side. And again, you can see that we've got some shadowing through here. And again, Emma's used her excellent technique, and you can see the reduction in the shadowing here. There's still a little bit of shadowing, but you can really see that this is normal tissue now. And we're getting a really good look right through to the pleura here, and she's managed to overcome that shadowing. When we find a lesion, it's most important that we document it really accurately. It's not good enough just to say that there's a lesion at 12 o'clock in the breast. We need to say which breast we're scanning, the exact o'clock position, and then use a ruler to measure the distance from the apex of the nipple to the lesion. And in this case, we've got 3 centimeters from the nipple, that's the FN, in the left breast at 12 o'clock. And what that means is that when this comes for a follow-up scan, maybe for a biopsy or a carbon track, or when we're actually trying to correlate it to the mammogram, we know exactly where that lesion was, and it's so important for follow-up. Scanning the area immediately posterior to the nipple can be a challenge. The first thing is to make sure that you've got your ultrasound room nice and warm. You keep the patient warm, so with a gown on, etc., before you begin the scan, and then use warm gel. This will make sure the nipple's nice and soft, and you get much better image quality. The second thing is that imaging the little ducts behind the nipple require the nipple to be rolled onto its side, because if you're looking straight down the line of the ducts, you're not going to get any definition. You need to have the ducts laying on their side so that we can see the interface and the contents of those ducts. So I never want to see another picture like this again. This is just someone scanning directly over the top of a nipple. It looks like there could be a massive breast cancer in there. Who would really know? And I think this is a completely inadequate technique, just to directly scan over the nipple. I don't mind scanning in underneath the areola component. That's okay, and shining the ultrasound beam in underneath the nipple, but certainly not using that technique. This is a gel loading technique where the sonographers put lots of gel and sort of drown the nipple, if you like, in gel, and then put the transducer and use a bit of a standoff there. And this does give a reasonable result, although I still don't think you can see the ducts using this technique, so it's still not my favourite technique. If I need to look at the nipple, if there's a discharge or some other nipple-related symptoms, then I use what's known as the rolled nipple technique, and it was developed by the wonderful Tom Stavros. So what you do is this is my index finger here, so I've got my index finger really on the edge of the areolar margin. Then using the transducer, I roll the nipple over on top of my index finger. That lays the nipple on the side, and then you can see this beautiful ducts here. You can see the walls of the ducts, and if there's a papilloma here, it really can't hide from me, and it is wonderful definition. So it's called a rolled nipple technique. And personally, I think it's the only way to go. Now, if you're thinking that, hang on, what if the lady has a fairly flat profile nipple or even a retracted nipple? Obviously, if the nipple is quite proud, it's very easy to do a rolled nipple technique. But I've never met a nipple yet that I can't get a good rolled nipple technique image from. Even if it's a retracted nipple, if you just take a bit more tissue as you roll it, you can still see the ducts in underneath it. And that's a really good way to get great images immediately of the ducts behind the nipple. Once you get these images, then you start to find things like this, which is a little papilloma. So you wonder, first of all, if this is a bit of imposated material sitting inside the ducts, but when you put the advanced dynamic flow on it here, you can see immediately this is vascularized tissue and this is a papilloma. And here's another example of a papilloma using a rolled nipple technique and the SMI technology showing this vascularity. Papillomas are really very commonly highly vascularized as opposed to just imposated secretions, which of course are avascular. In this case, we were hunting for some DCIS type calcifications behind the nipple, and using the rolled nipple technique, we can see really clearly these multiple little calcifications correlating to the mammographic findings. I'm going to attempt to demonstrate to you how I perform a rolled nipple technique using this pen as my nipple as a prop. So what I do is I place my index finger about 1.5 centimetres to 2 centimetres away from the apex of the nipple. So it sits really on, if you like, almost the edge of the areola. Then what I do is I bring my transducer in against the side of the nipple as so, and I dig it into the breast tissue, and then I roll the transducer over the top of my finger like so. And as I roll over the top of the nipple, what this means is I end up with my transducer being parallel to the ducts of the breast. This gives us really nice specular detail, a bit like if you're doing musculoskeletal work, really looking at tendon fibres, and this allows us to hunt for papillomas and other lesions, including calcifications immediately behind the nipple. This Tom Stavros technique is a game changer and will give you unique definition in the ducts behind the nipple that you can't achieve in any other way. This looks very similar to the papilloma that I've just shown you. However, the advanced dynamic flow in this case shows no evidence of any flow within it. This is just a little bit of imposated material, just a bit of normal secretion inside the duct. This is a breastfeeding lady, and this is scanning in the axilla, and so we have a palpable lump that's presented here, and this is just because of a blocked duct. So we have some accessory breast tissue in the axilla, and this has formed a galactocele. Let's talk about breast cancers. So there's all different types of breast cancers, and first we're going to talk about non-invasive breast cancers, which sounds like a contradiction in terms, but we can have ductal carcinoma in situ, so DCIS, and this is when we have a cancer that's forming in the breast, but it stays within the ducts of the breast. And then we have lobular carcinoma in situ, and this is where the cancer actually forms in the terminal ductal lactation units, the TDLUs of the breast, but does not invade into the breast beyond the TDLUs. So this is an example of a normal breast, and this is an example of DCIS, or if this was in fact in the lactation unit, this would be a terminal ductal lactation unit lobular carcinoma in situ, and this is what happens with invasive breast cancer. It actually breaks out of that barrier into the surrounding breast tissue. So DCIS is very difficult sonographically, and it's all about the mammogram and it's all about calcifications. So the job of the sonographer is not to scan a breast looking necessarily for these calcifications. The calcifications will be known because we'll know about them because the radiologist will tell us that they're there on the mammogram. And then our job is to hunt that part of the breast and find the calcifications and then determine whether or not there's any mass-forming lesion or whether we have just DCIS or whether it's starting to turn into a more aggressive breast cancer. So you could see on that previous mammogram all those little calcifications, and now sonographically you can see as I scan this breast here, you can see the little calcifications all scattered through this area. So the value of being able to find these with the ultrasound is not so much that we make the diagnosis, because the diagnosis is made from the mammogram, but the value here is we can now perform the core biopsy using ultrasound guidance and not having to use mammograms to guide the interventional procedure. So these are examples of DCIS, and you can see inside the ductal pattern of this breast, you can see these little calcifications. They line up in little rows all throughout the ducts. You can see them lining up here, and this is what DCIS looks like on ultrasound, and we can then biopsy these very effectively. Here's another example of DCIS. You can see the little calcifications lining up in the duct here. And is it just me, or does it look like these little calcifications actually can move along the duct? They almost look like they're slightly mobile to me. And I've never seen this sort of published or talked about, but I feel like these little calcifications are actually mobile. Here's another great example of DCIS. You can see this great aggregation of little tiny calcifications on the ultrasound, and this is really perfect for us to then guide the intervention. So if you use your ultrasound machine with the harmonics on, you can turn your dynamic range down a little bit and really look at the part of the breast that the radiologist has told you to go looking in, and hunt and hunt and hunt until you find these DCIS lesions. I think it is certainly doable with ultrasound. So here's another example. You can see the calcifications really easily on the mammogram. And then if you look in this part of the breast here, you'll see the calcifications all sitting. You can see they're actually inside the ducts, of course, because it's ductal carcinoma in situ. And these little calcifications, we then thought we could biopsy this with confidence. We know we're getting this part of breast tissue that we're interested in, and we can make the diagnosis of DCIS. Another thing you might come across, which is quite complex to look at with ultrasound, is this type of lesion called a radial scar. Now, when you stumble upon one of these sonographically, you'll just think, wow, there's just a really big breast cancer there. It's a really easy diagnosis. But these are radial scars, and in truth, they're not much better to have than a breast cancer. What they are is complex sclerosing breast lesions, and they're made in a stellate type configuration with a fibroelastic core that then entraps the ducts and lobules around it. So unfortunately, in the center of them, right in the middle, they often have some DCIS component. So they really need a core biopsy and often go on to have excision. But they do create these really mysterious looking images. The other thing with radial scars is they don't have to be after surgery. They can just appear in the breast without any surgery. And you can see this area here in the breast looks quite concerning, and here on the tomographic image it looks quite concerning as well. Then when we scan it sonographically, we can see this stellate type pattern, but this proves in the end to be a radial scar. But have a look inside at these little calcifications, and when we core biopsy this, we'll find out that there's actually DCIS inside this lesion. Another thing that can be very tricky is a post-surgical patient where they have a scar from a previous lumpectomy. And so when we scan this area, you'll see this shadowing lesion. You think, wow, how can I be sure if this is actually just the scar or whether we have a recurrence in this area? And I think this can be really difficult. So what we need to do is serial follow-up. So we have multiple chances to have a look at the same lesion, and we're looking for changes between the previous examination and the current examination. Another thing is that we can look with Doppler inside it. So use your SMI, use your advanced dynamic flow, and have a look inside the scar area. And scars that are more than 6 months old should not have any Doppler flow. And if you have some flow inside a scar that's 6 months old, then this is starting to suggest that maybe we have some recurrence, and it might prompt a rebiopsy of that area. Then we have invasive breast cancers, and they come in different types as well. So an invasive breast cancer is a breast cancer that has spread beyond those terminal ductal lactation units or beyond the actual ducts of the breast into the surrounding breast tissue. So it's spilled out of the ducts, out of the TDLUs, and it's now in the surrounding breast tissue. Locally advanced breast cancers are a little worse because these ones have then spread not only out of the ducts and the TDLUs, but now they're starting to involve either the skin, the pec wall, so the pec fascia of the chest wall, or they're getting into the lymph nodes up in the axilla. And then metastatic breast cancer, of course, is when it's metastasized widely into bone, liver, lungs, etc. Then we have a couple of other unusual types of breast cancer. The first one is Paget's disease of the nipple. Now, when we think of Paget's disease, we think of a bone disorder, and we don't think of it as necessarily a cancer-type condition. But with Paget's of the nipple, it is a breast cancer. So it's a rare type of breast cancer where the cancer cells grow in the nipple or in the adjacent areola. And it's a ductal carcinoma that migrates up the ducts and from the lobules up the ducts and then involves the nipple and the skin. And the skin becomes scaly and red, and it's often very irritated and itchy for the patients. So if a patient's disease is diagnosed, there's usually an underlying DCIS and possibly an invasive breast cancer. So these ladies will need to be treated as a breast cancer. These, I think, are the scariest of the lot, the invasive breast cancers that are inflammatory breast cancer in nature. So these patients turn up, and when you look at the breast, it's often firm, it's often warm, and it looks for all the world to me like it's a lady with mastitis. And then when you scan the breast, you'll notice that there's a lot of architectural distortion and there's something unusual going on there. And this is really easy to make a misdiagnosis of mastitis, and we see this unfortunately happen from time to time, and then eventually after antibiotics haven't helped, then we're left with a diagnosis of an inflammatory breast cancer. So what are the ultrasound characteristics we go looking for suspicious lesions? The first thing I look for is architectural distortion. So the breast has a normal horizontal architecture where things are laid out in a horizontal way. Anything that distorts this architecture is suspicious. Spiculations. obviously are very suspicious if the lesion has angulated margins and spiculations. A lot of breast cancers have a thin echogenic halo around it, like a desmoplastic reaction, so this is also a suspicious finding. A bit like in the thyroid, if it's tall rather than wide, then this is also suspicious. This is cutting through the layers of the breast. This is going through that normal architecture of the breast. If it has angular margins, as this example here does, then this is also very suspicious. If it is hypoechoic, if it creates some shadowing, if it has any microcalcifications, and if you can see it extending into the ductal system immediately adjacent to it, then these are all features of a breast cancer. Macro-Lobulation is also suspicious, particularly for the more cellular type of breast cancers, and then any vascularity makes it suspicious for a breast cancer as well. So let's have a look at some of these characteristics one by one. So assessing for architectural distortion, we're going to see architectural distortion in breast cancers. We're also going to see it in radial scars. We're going to see it in post-operative breasts where the surgeon has cut through the tissue, creating some architectural distortion. You can see the way here that these horizontal lines have become disrupted. So you can see there's a natural line through there, through there, through there, and these have all become cut, and this breast cancer has grown up through them, and this has really distorted the natural architecture of the breast. This is an example of spiculation, and you can see the way that this breast cancer is really spreading in a star-like fashion, and it's invading the tissues in a radial fashion all around itself. And then you can see with the SMI how there's a lot of flow in the central nidus of this breast cancer. This is an echogenic halo, so it's what we call a desmoplastic reaction. You can see around the edge of this breast cancer there's this echogenic rim, and you can see also there's a lot of tethering of the tissue, and there's a lot of disruption and distortion of the normal architecture of the breast here. This is really typical of a breast cancer. These are three examples of very tall lesions, so they're taller than wide, they're all hypoechoic, and these are fairly obvious breast cancers. Here we have angular margins, and what I really don't like with an angular margin is when they reach for the transducer, so they go vertically through the tissue. If you look at this example here, if you just looked at this part of this example, it doesn't look too bad. It just looks like a macro-lobulated little area in the breast, and I wouldn't have thought too much of it, hopefully just a fibroadenoma. But the moment it sent up these two periscopes that came straight up towards the transducer, then these little vertical elevations here, these angular margins that these create, this makes this highly suspicious for a breast cancer, and both of these, of course, did prove to be breast cancers. If it is hypoechoic, a lot of breast cancers are hypoechoic. In fact, it's very unusual to see an echogenic breast cancer. They can be quite isoechoic occasionally with the surrounding breast fat, but most are hypoechoic in nature. And then this is examples of shadowing. Now, these are two tiny little breast cancers next to each other, and you can see the shadowing here. In fact, because we're using my compound, you can see a shadow down through here, you can see a shadow down through here, and you can see another shadow down through here. And this is because I've got my compounding on. If you wanted to make this shadowing more conspicuous, you can turn your compounding down or off, and you'll just get one denser shadow behind it. So these little vertical, these are really tiny little breast cancers. They're sitting side by side, a little bit of vascularity in each, and both of them are causing a little bit of shadowing behind, and these are typical of breast cancers. Here we have some microcalcifications, and I don't know why we call them microcalcifications. I can see them, so they're macrocalcifications. But you can see these are calcifications sitting inside this little stellate type lesion. It's hypoechoic, and you can actually see some ductal extension too. If you look at it, it's actually sticking its little tentacles into this duct, and it's going to invade up the length of this duct here. You can see what it's trying to do, and it's becoming quite star-shaped in its appearance. Very typical breast cancer. This one has already invaded the ducts, and you can see the way that there's a good piece of this that's marching up this duct. I call this like an elephant trunk. It'll trunk up towards the nipple, and eventually will start to cause some nipple symptoms as well. You can see some calcifications in this lesion also. Macro-Lobulation is associated with often fibroadenomas, but also with these cellular type of breast cancers. So this looks like it could be a fibroadenoma, but it is in fact actually a very cellular breast cancer, unfortunately. Vascularity inside a lesion always increases the likelihood of a malignancy, and this is again that very cellular lesion. So it could be a fibroadenoma with some vessels in it. However, it's slightly angular shape, it's vertical orientation, and its hypervascularity. Of course, it was going to get biopsied, and this came back as a cellular breast cancer. So this is really your classic breast cancer. It's hypoechoic, hypervascular. It's got the echogenic rim. It's fairly attenuative, it's spiculated, and it cuts through those horizontal tissue planes in an unruly fashion as it's aggressing its way through the breast. This is a really great example of a malignant lesion and the ultrasound having perfect correlation with the mammogram. This mammogram is a tomographic mammogram, and you can see that when you look at this lesion here, you can see that peripherally around it really has this spiculated type pattern, where it makes you feel like the actual size of the lesion and its invasive process is more extensive than the central nidus of the cancer itself. If you look at the sonogram, you can see exactly the same pattern. You can see the spicules running out through the tissue in a radial fashion here, and this is a great correlate with the mammogram. So really, I think if you look at that mammogram carefully there, I think that is the dimension of the invasive margins of this breast cancer, not just the central nidus. The challenge for us becomes with demonstrating these really tiny lesions, but really we comb through the breast looking for exactly the same features as I've just described. So this is a little vertical lesion that's hypoechoic. It's got quite ill-defined margins to it. It's hard to see the margins of it. And this is very suspicious of a small breast cancer. So these are the type of things we're looking for, these very, very early breast cancers buried in the glandular part of the breast. The acoustic properties in terms of shadowing of lesions does tell us something about the lesions. Now, these two breast cancers have fairly aggressive shadows behind them, and these tend to be low-grade lesions. So they're usually not vascular. They have a high fibrous content, and these are not the worst type of breast cancer to have. These type of lesions are much more aggressive. So these are the cellular type of breast cancers, and you can see with this one, it's again quite spiculated. It's very aggressive as it's moving through the breast. You can see there's a really obvious lymph node involvement as well. But look at the through transmission. That's really neutral, almost enhances. And so these tend to be papillary or mucinous carcinomas, and these are more aggressive. So this is just another example of a cellular malignant breast cancer. You can see that there's very, very good through transmission, but all the other features suggest that it's a malignant lesion, and of course it is a highly cellular malignant lesion. This one could have almost been considered fibrocystic change with the little cystic spaces. However, with the SMI, you can see the vascularity here. This is clearly a lesion, and this is a cellular breast cancer. This is a cellular breast cancer, again looking very spiculated, and in fact it's part of a multifocal process. So it's really important once you find a breast cancer not to sort of just rest on your laurels, but you need to go looking for others. So in this example here, you can see I found the primary breast cancer, I found a satellite lesion, which we're scanning to now, and then as I scan further out, I scan into the axilla, and you can see there's a malignant lymph node. So make sure you correlate with the mammogram. If it's a very dense mammogram, make sure once you've found one breast cancer that you go looking for others. Here's a really good example of this. So we were looking in this breast here, this area here, and this is a magnified view from the tomogram from it. And you can see the way that it's got these sort of streaky extensions. And what this is a small breast cancer, and it's actually infiltrating along the ducts heading towards the nipple here. So when we scan it with ultrasound, you can see that we find the primary lesion, which is here. And then as I scan, you can almost follow the ductal tissue path as I scan through. You can get all the way through until you get to the second lesion. So you can follow one lesion all the way to the second lesion. This was a concerning breast cancer because it had this highly vascular pattern in the center of it. And although it was only a small breast cancer, have a look in the axilla. There's a really obvious malignant node in the axilla. So what I'm doing here is I'm scanning from one part of the lesion through the ductal pattern of the breast, and then I arrive magically at the other lesion. So it's multifocal cancer, and you can almost follow the tissue path, the ductal pattern between them. If I start this other video, you can see here's one lesion here, and you can actually see a little chain of, there's a little microcalc there, another one here, there's another one up here. So we've got this little chain of calcifications, and the other lesion was just off the screen here, so we can actually tie them together. Here's another example of a different patient where, again, we've got satellite lesions. So I've literally scanned from one lesion through to the other here. So it's quite often that they're sort of in the same ductal line. And so I've found one lesion here, and then I'm just scanning sort of either towards or away from the nipple along the ductal line, and I find the second lesion in the same line. They're actually connected up together. So this is multifocal malignant lesions. The next thing a breast cancer can do is start to invade not just the breast tissue around it, but in this case the skin. So you can see this one's reached up to the dermis, and you can actually see when you examine the patient clinically, you can see the skin damage that's starting to happen with the skin changes. This is a breast cancer going the other way, and you can see here this is a very large breast cancer, and then you can see this direct extension here has actually made its way. This is the pec major muscle, and you can see it's actually sitting inside pec major underneath the breast itself, so it's a direct invasion of the pec fascia. Here's more examples of direct invasion. So you can see this breast cancer is tracking up through these ducts, heading up towards the nipple. This is what I call those elephant trunks that come up. And in this case over here, you can see that the same breast cancer, in fact, has then made its way into the lymph nodes as well. And this is a malignant looking lymph node with quite puffy cortex on that aspect of it. This is another example of how locally invasive breast cancer can be. You can see on these two mammograms, we've got the MLO and the CC here, how there's a very obvious stellate breast cancer lesion. You can follow the tentacles of this breast cancer out quite some distance, so you can see that it's locally invading deeply into the breast tissue and has quite a large radius at the periphery. You can also see the distortion that it's making to the skin line here. So when we examine this lady clinically, you're going to see some puckering of the skin and a bit of dimpling of the skin here. And this is a really good sign that there's something invasive going on underneath, and it's these far-reaching tentacles. The breast cancer is a long way from the skin, but it's these far-reaching tentacles that are reaching out and then causing that puckering and distortion of the dermal layer. On the ultrasound, you can see the central nidus of the cancer here, and this correlates exactly to the same shape, really, as the breast cancer here. But you can also appreciate on the ultrasound how there's this sort of tentacle-like spreading of the cancer through the tissue planes in all directions. So although we measure a breast cancer by measuring the central nidus of the breast cancer, you can appreciate on the ultrasound, just like the mammogram, how extensive and invasive this breast cancer is. Modern mammography also uses this tomosynthesis technology, and I think this technology really shows even better again how aggressive and invasive the breast cancer is, and how it follows these lines of attack through the breast tissue in this stellate nature in a radial pattern around the breast cancer until it reaches the skin and starts to pucker that. And then, of course, if it's more posteriorly placed, it may reach the pec fascia as well and invade that as well. And again, you can see on the ultrasound how this really shows a very good correlation in terms of the exact location, and as well as the shape of the breast cancer, as well as even a couple of punctate calcifications that are apparent on both imaging modalities. So when we look at the ultrasound itself, you can see the stellate invasion going in a peripheral way, circumferentially all around the breast cancer. We have a couple of little macro-calcifications that sit in this area here as we scan through, and you can really appreciate the far-reaching and stellate invasive nature of this breast cancer in such a good correlation. We also have plenty of benign lesions in breast, so we see cysts all the time in breast. Benign lesions don't go through tissue planes, they're soft, they push fascias away, and they look completely different to malignant lesions most of the time. Some of them are not even breast related. These are examples of sebaceous cysts. So here we have just two examples of a sebaceous cyst. You can see the punctum here, and these are just skin lesions, so nothing to do with the breast at all, just skin related lesions. And then we have cysts that are a little more complex in nature. So these little sort of snow dome type cysts are full of debris, don't worry me at all. This is just a multiloculated cyst, that's fine as well. This one's got like a fluid level, and in these ones you need to make sure that this is not a solid component here, and you can see it's not. The Doppler here is not showing any flow within it whatsoever. It's interesting, the radiation effect of the ultrasound is actually causing some convection inside the cyst next to it. And then these are more complex cysts. So these cysts start to have more complex interiors. This one I'm not really worried about because it's got no flow in it whatsoever with the Doppler. This one, however, the complex component of it here, the solid component, does have some Doppler with the SMI, and this will require a biopsy. A fluid level is a really good indication that you've just had hemorrhage into a cyst. So there's two things. If you see the fluid level, that's encouraging. The second thing is you're not going to see any flow inside it when you use the Doppler. So in all these cysts, you can see there's nice fluid levels. And in this sort of comical type picture here, you can see this is just a cyst with some hemorrhage in it, no flow at all whatsoever, and nothing to worry about. This is fibrocystic change in the breast, looking at it with different transducers. In the top left-hand picture, you can see I'm looking at it with a lower frequency transducer. The top right-hand, it's a bit higher frequency transducer. And then the bottom images, I'm looking at it with the the microscope, if you like, with the hockey stick transducer. And it's not until I look at this lesion with the hockey stick transducer, because it was quite superficial in the breast, that you can really see that it is just fibrocystic change. It's got little fine septations, and there's no vascularity at all with the advanced dynamic flow. So I'm happy to call this fibrocystic change. If it had some vascularity, I would think different about it. Just shows the importance of using different transducers when you're targeting a lesion, trying to work out exactly what it is. This is a mistake you never want to make, and that is calling a breast cancer a cyst. So some breast cancers, particularly the cellular ones, can be really sort of very hypoechoic, and they can have quite clean margins. Now, when you look at the margins here, they are a little bit fuzzy, so it doesn't really look like a cyst. But if you want to just turn the gain down a little bit, you can make it look completely black. And then you can think, oh, I'll just call that a cyst, whereas in actual fact it's a solid lesion. So always be honest. Turn your gain up, have a look for internal architecture changes, and never make the mistake of calling a breast cancer a cyst. This is an interesting case where we have two pathologies coexisting very close to each other. Unfortunately, here we can see there's a very obvious stellate carcinoma. So this is an invasive breast cancer, and you can see it has the typical features of this sort of angular margins, spiculated, aggressive approach to the surrounding tissue. You can also see it here on the MLO. However, on the MLO and also here on the CC, there's another small area here, and you can see it here. This has a very sort of soft center to it, so it almost looks like a fatty center. And then on the tomogram here, we can see that there is indeed a well circumscribed small round lesion with what looks like a fatty center to it, and this is a breast hamartoma. So it's a fibroadenolipoma, and it's sitting immediately adjacent to a breast cancer. Now, breast hamartomas are rare, they're benign, and they can occur in various organs throughout the body, but in the breast they contain glandular epithelium, fat and fibrous tissue, and they have this unique appearance on the ultrasound and the mammogram where they look like a fairly well circumscribed sort of fatty area inside the breast. These can be mistaken easily for a more sinister lesion, and this may be one of the areas where breast elastography can be particularly useful, because a hamartoma, because of its fat content, will appear very differently to a fibrous breast cancer using elastography. Sometimes the area in a breast of concern is simply a piece of fat. In this case, it's a true lipoma, and I may have moved this caliper out to here, I think, but this is a lipoma sitting within a breast. And in this case, this is just an island of normal fat sitting within the breast tissue itself, and this is creating the lump that the lady can feel. We also see encapsulated fat inside the glandular component of the breast very commonly. In this case, there's a very clear, palpable lump. However, sonographically, there's really nothing to see. So what I do in cases like this is I use my index finger on my left hand, and I run my finger over the lump that I can palpate with the transducer immediately adjacent to my finger. And what you notice here is that this little fat lobule here, this little lobular fat here, just feels firmer than the surrounding fat. And what this does is it ensures me that I have a good clinical correlation, that the palpable lump that the lady can feel, the referrer, and I can feel as well, simply correlates to a slightly firmer but normal lobular fat. This is fat that's had some trauma to it, so this is fat necrosis. If you have trauma to the breast, and I've actually had a lady recently who had a similar appearance to this, who said that she'd been injecting her recreational drugs directly into her breast that had caused an area of fat necrosis as well. And this is fat necrosis or an oil cyst. So you can see in this area here, the breast is very prone to trauma. It's very commonly traumatized by different types of sports like AFL and netball, and of course by seatbelt injuries, these type of things. And this causes fat necrosis that move on to be an oil cyst, and they often become calcified like this one. Another thing that can happen in the breast is infections. This is a breast abscess. This is a recent case that the radiologist said to me, just go and document this large breast cancer for me. When I came back, I said, it's not a breast cancer, it's just an extensive abscess. And you can see the way that the fluid in the abscess sloughs about, and you can see the way that there's vascularity and echogenicity of all the surrounding fat around the phlegmon, but the phlegmon itself doesn't have any flow within it. Here's another breast abscess, and again, classic flow around, but nothing inside the phlegmon itself. This is breast trauma. So this lady fell over heavily and landed, unfortunately, on the jockey wheel of a trailer, which just makes the hair on the back of my neck stand up. And when I scanned her, she had this large hematoma. You can actually see it's still actively bleeding into itself. So there's actually a little perforated artery here that is continuing to bleed, and this is still a growing and active hematoma. One of the very common lesions, benign lesions, we'll see in breasts are fibroadenomas. We see them in the younger ladies between 20 and 40. They're solid, they're well circumscribed or macro-lobulated. They're usually a little hypoechoic, often isoechoic with the breast fat. And you can have them multiple throughout the breast. They can be vascular. And occasionally you see calcifications in them. So this is your typical fibroadenoma. So you can see the way that it is hypoechoic. It's a easy to palpate lesion. It's got some vessels in it. It's macro-lobulated. But what it doesn't do is it doesn't really break up that architecture of the breast. So it doesn't cut through those horizontal lines. It simply displaces them around. This one again is hypoechoic. It's macro-lobulated. It's a little angular though, this one. So this one was a little more suspicious, but still proved to be a fibroadenoma. More examples, and you can see the way that these just really fit nicely into the breast parenchyma. They don't really aggressively try and cut through any lines, and this is the hallmark of a fibroadenoma. This one's a little more funky. I'm not sure about this fibroadenoma when I scanned it. I thought we might be dealing with a breast cancer, actually a cellular breast cancer, because it's very vertical, and it's also very vascular. But in the end, this proved just to be a fibroadenoma. When you see calcifications in them, and you can see actually with the Doppler here, you can see the comet tail artifact from the calcification as well. This is a degenerating fibroadenoma, and this is what happens. This is why we don't see them in the older lady population. Is they degenerate and then they burn out like this one has. They calcify and then they disappear, and they just leave a remnant on the mammogram of a small bit of calcification. Sometimes making your mind up whether you're looking at a fibroadenoma or simply some entrapped fat can be very challenging. All of these lesions are proven fibroadenomas. The key here is the subtle difference in the echotexture between this lesion and the surrounding subcutaneous fat, and perhaps a little twinkle of SMI here that's genuine as well gives this one away as a fibroadenoma. In this case, you can see it's even more challenging, I think, where there's not a lot of subcutaneous fat to compare with, and the echotexture is very similar. However, this will show on the mammogram as a lesion, and secondarily, it will be palpable as well quite often. So sometimes the clinical assessment correlated with the ultrasound is the way to come to a final determination. Just to highlight how difficult it is, this is a case here. Both these videos here are just showing some normal entrapped fat. I'm using different frequency transducers in both images, and it looks like there could be a fibroadenoma in this breast tissue. However, the answer to this riddle is this is simply entrapped fat, and this on this side is the same image I just showed you, and this is a proven fibroadenoma. So you can see how this can be quite a challenging situation. And these are the type of cancers that really bother me, because these are the ones that can look a little bit like a fibroadenoma. They don't look typically like a cancer, but these are all cancers. So these are papillary cancers. They're highly cellular cancers. You can see that it is a little bit vertical. It does have a little bit of an echogenic ring around it. So there are some concerning features. It's slightly angular, but really, how much different does it look to a small fibroadenoma? Not particularly different. And this one has some cystic spaces and some solid areas as well. This is another papillary cancer. And these are also examples of cellular cancers. So these are cellular cancers, proven cellular cancers, but and proven by this biopsy here. But really, what's the difference between this sonographically and a fibroadenoma? Not much. And that's why we have this subcategory of indeterminate lesions. When we see something inside the breast that looks a little bit solid, it might have a little twinkle of SMI signal inside it here. So you're wondering if this is a little bit of a small papilloma or a small cancer starting to form in the TDLUs of this breast. This requires a biopsy, especially given that SMI signal when we look so carefully. Another type of tumour that you might come across is a phylloides tumour. So this is a different type of tumour again. It's a connective tissue tumour arising from the tissue that supports the ducts and the lobules of the breast, so the interstitial tissue between these components. They can be benign, but unfortunately they can be malignant or they can be mixed. So unfortunately we need to biopsy these, and often they need to be excised, as when they do have a malignant component, it's a sarcomatous component, which is obviously not ideal. But even when it is a sarcoma, they're interesting is they don't particularly metastasize aggressively through the lymph nodes, but they still need to be excised. So this is a phylloides tumour, and they can be massive. So it looks for all the world like a giant fibroadenoma, but this is a very, very large phylloides tumour, and it's not uncommon for them to reach this size. In fact, really, I really wonder why these ladies present so late when they come for their scan. The next thing is the axilla. So the axilla is part of a standard breast ultrasound. We can't not look at the axilla. And when we look at the axilla, we need to consider that there's 3 specific levels of lymph nodes that we look at. Those lymph nodes are allocated level 1, 2, and 3 based on this muscle here. And this is the pec minor muscle. It comes from the ribs, and then it has its origin up here on the coracoid process. If we are scanning lateral to the lateral border of pec minor, these are level 1 nodes, and these are the ones that sit really right in the armpit, if you like. If you see lymph nodes deep to pec minor, so between the chest wall and pec minor, these are level 2 nodes. And level 3 nodes sit medial to the medial border of pec minor. They also like to sit down here along the edge of the sternum. You see them in these little intercostal spaces here. And then they can come up into the around the clavicle and then go into the supraclavicular area, what we would call level 4 of the neck. And this is also where breast metastases go through the lymphatic system. So these are level 1 nodes. You can see I've annotated there pec minor and pec major for you, and see that you can see these lymph nodes. The ones on the left are fairly benign looking nodes. The ones on the right have a more malignant type of characteristic to them, but these are level 1 nodes because they're sitting lateral to pec minor. These are level 2 nodes. They also don't have a fatty hilum. They look concerning, and this patient had a known breast cancer that are already diagnosed. And you can see these are immediately underneath pectoralis minor. So these are level 2, or what some people refer to as rotter nodes. And these are level 3 nodes. So these are sitting medial to the medial border of pec minor. And so really where I'm scanning here is adjacent to the sternum. You can actually see these are the ribs coming off, so the costal cartilage, and then you can see just adjacent and just deep to these ribs, these are the lymph nodes that are sitting in level 3. So the next place these will go is up into level 4 of the neck, into that supraclavicular fossa. We see normal lymph nodes in the axilla regularly, and they should be oval in shape. They should have a smooth margin, and their cortex should be nice and thin, less than 3 millimeters, and uniform all the way around. They should have a fatty hilum in their center, and if we put the Doppler on, we see a standard sort of hilar flow, a little bit like a kidney. So this is a normal node. You can see it's got a large fatty hilum here, and it's got a nice little thin rind of cortex around. So this is not concerning whatsoever. Seeing nodes like this is completely normal. We can sometimes see lymph nodes inside the breast itself, and these are intramammary lymph nodes, and you see them down the lateral aspect of both the right and left breasts quite commonly. They have the same characteristics. They've got a little fatty hilum, an evenly thickened and evenly thick little cortex around the outside, and if you put the Doppler on, you'll see a little hilar blood supply flow to them as well. But this is an abnormal node. So when we look at this node, you can see that there's one area of it just sort of stands out as having a thick cortex, and that's because this is being invaded by a breast cancer that's metastasizing to this lymph node. So seeing this asymmetrical thickening of the cortex in a particular area, more than 3 millimeters in diameter, is concerning and requires a biopsy. Here we have an obvious breast cancer on the left-hand image, and on the right-hand image we're biopsying a node because it has, again, that little focal area of thick cortex there, and this comes back positive for a metastatic deposit into the lymph node from that breast cancer. This is a really obvious one, so you can see this lymph node's it's actually a much bigger lymph node than it looks like. It goes all the way around off the screen here, but it's got this big area here that's like a big focal area of cortical thickening with this really weird blood supply to it. So this is clearly a malignant lymph node. And then eventually, if the breast cancer continues to spread, before it turns into metastatic breast cancer, it gets into these supraclavicular lymph nodes. So these are included in the level 3 type category, so the ones that are medial to the pec minor muscle, the ones adjacent to the sternum, and then around the clavicle, and then above the clavicle into level 4 of the neck cervical lymph nodes, supraclavicular nodes, and these are associated with breast cancer, of course. I hope you've enjoyed this presentation on breast ultrasound. Please feel free to stay in touch with me at this email address, stayintouch@birdultrasound.com.au, and ask questions about the material in this presentation. Also, please visit birdultrasound.com.au, where you'll find many more presentations on a wide range of subjects. Happy scanning, and bye for now.